It's time for another warm-up review. Let's get going. What are some examples of substances eliminated at a constant rate, or zero-order elimination? So remember the mnemonic PEA, and a P is round like zero. So PEA stands for phenytoin, ethanol, and aspirin. Next, which enzymes are used to metabolize alcohol? So alcohol dehydrogenase metabolizes ethanol to acetaldehyde, and then acetaldehyde dehydrogenase metabolizes acetaldehyde to acetate. Next, which cranial nerve nuclei are located medially in the pons? So you can remember that the nuclei for cranial nerves 5, 6, 7, 8 are located in the pons. And then remember that the nuclei are located medially in the brainstem. Those are going to be the ones that are divided evenly into 12, which will be cranial nerve 3, 4, 6, and 12. So the only cranial nerve nucleus in the medial pons is cranial nerve 6. All right, that's it for the review. Let's get to that video.
Hey everyone, my name is Dr. Emil Tazjoy, and I'm an OB-GYN in Dallas, Texas. It's nice to be with you all today, and good luck studying. So in this video, we're going to review the female reproductive cycle. The reproductive cycle is about reproduction, from producing a mature egg and releasing that egg so it can be fertilized, and also to make sure that the uterus is able to support a pregnancy if fertilization occurs. So let's begin at the beginning with oogenesis. Oogenesis is the process by which the ovaries produce a mature egg, and it begins even before birth, during fetal development. We start with a diploid cell called an oogonium, which has 23 pairs of chromosomes, or 46 chromosomes total. The oogonium begins meiosis during fetal development, and once it begins that first meiosis, it's called a primary oocyte. The primary oocyte enters meiosis, but then stops at prophase 1 and goes dormant. So the primary oocyte is arrested in prophase 1, and that's where it stays for years and years until puberty. Then right before ovulation, the primary oocyte resumes meiosis. It finishes meiosis 1, and then cell division occurs, producing a secondary oocyte, which is haploid, plus a polar body. Then the secondary oocyte starts a second round of meiosis, but then it is arrested in metaphase 2. This secondary oocyte is the cell that is released at ovulation, and if fertilization occurs, it completes meiosis 2, resulting in a mature haploid ovum and another polar body. So, primary oocytes are arrested in prophase 1 until right before ovulation, and secondary oocytes are arrested in metaphase 2 until fertilization. Next, let's review how the hypothalamus and the pituitary and the ovaries interact in order to regulate the reproductive cycle. First of all, the hypothalamus releases gonadotropin-releasing hormone, GnRH, and it releases GnRH in a pulsatile fashion. That pulsatile release of gonadotropin-releasing hormone tells the anterior pituitary to release the gonadotropins, which are FSH and LH. FSH stands for follicle-stimulating hormone, and LH stands for luteinizing hormone. FSH and LH then bind to the receptors in the ovaries, which leads to follicle maturation and ovulation. And the ovaries produce estrogen, progesterone, and inhibin, which provide negative feedback at the hypothalamus and anterior pituitary. Now let's look at the ovulation a little more closely. Each primary oocyte is found inside a primordial follicle. This primordial follicle contains the primary oocyte surrounded by a layer of supportive cells, such as the granulosa cells and the theca cells. These are the cells that actually produce estrogen and progesterone, as we'll see in a moment. Every month, when the FSH starts flowing from the pituitary, several primordial follicles begin to grow and mature, which is depicted as you follow the follicle counterclockwise. FSH is follicle-stimulating hormone, so it stimulates the follicles. And eventually, one follicle becomes dominant, and that becomes the Graafian follicle. It will release its oocyte, while all the other follicles will degenerate so that only one is released each cycle. Once that oocyte is released, what's left of the Graafian follicle becomes the corpus luteum, which secretes a lot of progesterone and also smaller amounts of estrogen and inhibin A. If pregnancy occurs, the syncytial trophoblast produces HCG, which maintains the corpus luteum so that it can keep producing progesterone until the placenta develops to the point where it can produce its own progesterone. That was covered in the Foundations video when embryology was discussed. If pregnancy does not occur, there's no HCG, so the corpus luteum degenerates and progesterone levels start to fall. Let's talk a little bit more about estrogen and progesterone. There are three main types of estrogen. Estradiol is the most potent of the estrogens. It's produced in the ovaries, and it's the most important estrogen in women. It's what keeps your skin young. You can remember it as the one that's to die for, estradiol. Estrone is found in both men and women. It's produced mainly by conversion of androgens that were produced by the adrenal cortex. This conversion is catalyzed by the enzyme aromatase, which is found in adipose tissue. Estrone, think Stallone. It's also found in men. And then finally, estriol is produced by the placenta during pregnancy. And this is the weakest estrogen. Remember this by thinking estriol is like a tree. The roots are complex and weave around just like the vessels of the placenta. And it's the weakest because it supports babies via the placenta, and babies are vulnerable and weak. So estradiol is the most potent, then estrone, then estriol. Now, I mentioned that FSH and LH stimulate the ovaries to produce estrogen, specifically estradiol, and the granulosa cells and theca cells, which were those support cells that surround the primary oocyte. But neither cell can produce estradiol by itself. It takes both types of cell. This is called the two-cell theory of estradiol production. LH acts on the theca cells to facilitate the entry of cholesterol, which is converted through a series of steps to androstenedione. This requires the enzyme desmolase. Then androstenedione diffuses into nearby granulosa cells where the enzyme aromatase converts it to estrone, which is then converted to estradiol. And FSH is involved in stimulating the granulosa cells. So it takes two different enzymes found in two different cell types to produce estradiol in the ovaries. And when you think about the functions of estradiol and estrogens in general, I want you to think growth. Estrogen causes growth of the female reproductive organs like the ovaries and fallopian tubes, the uterus, the vagina, and the external genitalia. It also stimulates development of the breasts and the ductal system of the breasts, and proliferation of the endometrium. In fact, women with excess unopposed estrogen states, such as what happens in polycystic ovarian syndrome, can lead to continued proliferation of the endometrium, which eventually leads to dysplastic changes in the endometrium and ultimately leading to uterine cancer. Estrogen also inhibits osteoclasts in the bone, so in a way it stimulates bone growth. And this is why the risk of osteoporosis increases after menopause. Estrogen levels drop and you lose that beneficial estrogen effect. Estrogen also increases HDL levels and decreases LDL levels. Pretty good. And what are the functions of progesterone? As the name implies, progesterone is progestational. It's important for getting the body ready for the pregnancy and supporting pregnancy. Progesterone inhibits endometrial proliferation. Like I mentioned earlier, when women encounter states of excessive endometrial proliferation due to unopposed estrogen, what is the treatment to reverse those early dysplastic changes on the endometrium? It's progesterone-derived hormones, which is the mechanism by which the IUD, or intrauterine device called the Mirena, works. Progesterone also promotes secretory changes that prepare the endometrium for implantation. Progesterone promotes secretory changes in the breast so that the breasts are prepared for milk production. Progesterone causes the cervical mucus to become thick and viscous to block additional sperm from entering the cervix after fertilization has already taken place. This also helps to prevent infection. This is also one of the mechanisms by which the Mirena IUD prevents pregnancy. Progesterone inhibits uterine contractions, which is beneficial during pregnancy to prevent a miscarriage. And progesterone relaxes smooth muscle in general. Now, ready to tackle the menstrual cycle. I'm sure you've encountered this chart once or twice before. It can be pretty daunting, so let's take it slowly. So across the top, you see what's happening in the ovary, from the follicle to the degenerative corpus luteum. Below that are the levels of various hormones, and the background shows the relative thickness of the endometrium as it gets thicker and prepares for a possible pregnancy, and then sloughs off during menstruation. Across the bottom is a timeline. The average cycle length is 28 days, and you'll notice that the menstrual cycle is divided into two phases: the follicular phase, or proliferative, and the luteal phase, or secretory phase. And the event that separates these two phases is ovulation. The follicular phase is where you have the growth of the follicle in the ovary, which is driven by FSH, follicle stimulating hormone, and FSH is stimulating the follicle to produce estrogen, which causes the endometrium to proliferate and become thicker. This is why the follicular phase is also called the proliferative phase, because the endometrium is proliferating and getting thicker so that it's all ready to go in case fertilization and implantation take place. Eventually, the rising estrogen levels triggers a surge in the levels of LH and, to a lesser extent, FSH. About 1 day after the LH surge, around day 14, the follicle ruptures and it releases its egg, and that, of course, is ovulation. So the LH surge triggers ovulation. And we've already discussed how the empty follicle becomes the corpus luteum, which secretes progesterone and some estrogen. That's why this is called the luteal phase. So the luteal phase is LH and progesterone dominant, while the follicular phase was FSH and estrogen dominant. And unlike the follicular phase, the length of the luteal phase is pretty consistent, right around 14 days. And note that as the progesterone level rises initially, it causes a tiny half-degree spike in body temperature, which occurs about 1 day after ovulation. The rising progesterone levels provide negative feedback at the hypothalamus and the pituitary, so FSH and LH levels decrease. The low LH levels eventually cause the corpus luteum to degenerate, leading to a rapid fall off of the estrogen and progesterone. And when that happens, there's nothing to maintain all that thick endometrium, so it sloughs off, and that's menstruation. We've also included a list of the main steps of the female reproductive cycle in your study guide. First, there's an increase in FSH, which stimulates follicle maturation. The follicles produce estrogen, so estrogen will increase, and initially estrogen inhibits LH and FSH. But at some point, there's a switch from negative feedback to positive feedback, which causes the LH surge, and that triggers ovulation. Then the corpus luteum forms and starts producing progesterone, as well as some estrogen. And the progesterone and estrogen feed back and inhibit FSH and LH production, so those levels drop. As LH and FSH levels decrease, the corpus luteum degenerates, so it'll stop producing progesterone and estrogen, and those levels will fall, which leads to menstruation. And with low levels of estrogen and progesterone, there's decreased negative feedback on FSH production, so FSH will increase, and that brings you back to step 1. So the cycle can begin again, circle of life, or whatever. We started out this video by saying that the purpose of the reproductive cycle is pregnancy. So let's talk about how this has to happen in order for pregnancy to occur. Again, we covered most of this in Foundations 1, but let's review it one more time. The first step is ovulation. The egg is released from the ovary. The fimbriae of the fallopian tubes sweep the egg into the tube, which is lined by cilia that move the egg towards the uterus. Fertilization has to occur within about a day of ovulation, and fertilization usually occurs in the ampulla of the fallopian tube. Then, 3 to 4 days after ovulation, the embryo enters the uterine cavity, and then implantation occurs on the 6th day after fertilization. Then, the syncytiotrophoblast cells start secreting human chorionic gonadotropin, HCG. And what did we say was the main function of HCG? To support the corpus luteum and to keep it from degenerating so that the corpus luteum can continue to produce progesterone until the placenta takes over around week 6. And that way, HCG acts a lot like LH. In fact, HCG and LH share an alpha subunit, along with FSH and TSH. The beta subunit is specific to HCG, so that's what we test for with our pregnancy tests. You can detect HCG in the blood about 1 week after fertilization, and you can detect it in the urine about 2 weeks after fertilization. HCG levels will remain high during pregnancy, and estrogen and progesterone levels will be high as well. Do you remember what type of estrogen the placenta produces? Estriol, which is the least potent estrogen. Let's finish up with a quick review of lactation. Milk is produced in the alveoli, and a cluster of alveoli makes up a lobule, and these lobules drain into the ducts, which empty out at the nipple. Milk production is stimulated by the hormone prolactin, which is produced by the anterior pituitary. You may also see this called milk secretion, because the milk is produced by glandular tissue and then secreted from the cells into the alveoli. And then the milk will sit there, and the hormone oxytocin causes it to move into the ducts. This process is called milk letdown or milk ejection. Oxytocin comes from the posterior pituitary. So prolactin is needed for milk production and secretion, and oxytocin is needed for milk ejection or letdown. And both prolactin and oxytocin are released in response to the baby suckling. Estrogen and progesterone also play roles in lactation. During pregnancy, remember that the placenta is producing high levels of estrogen and progesterone, and those hormones inhibit milk production. But after delivery of the placenta, the levels of estrogen and progesterone drop. You lose that inhibition, and that allows prolactin to stimulate milk production and secretion. Now it's time for the end of session quiz. First question. During what stage of meiosis is the primary oocyte arrested? The primary oocyte is arrested in prophase 1 of meiosis 1. And it stays there until just before ovulation, which is when it becomes a secondary oocyte and enters meiosis 2, and then is arrested in metaphase of meiosis 2 until fertilization. Next, which hormone, estrogen or progesterone, is responsible for each of the following actions? Production of thick cervical mucus that inhibits entry of the sperm into the uterus. That's progesterone. Induces LH surge. That's estrogen. Relaxes uterine smooth muscle. Is progesterone. Stimulates endometrial proliferation. That's estrogen. So excess estrogen is a risk factor for endometrial cancer, which we talked about. Inhibits endometrial proliferation is progesterone. So progesterone protects against endometrial cancer. Next, HCG has an alpha subunit identical to which other hormones? The hormones that share the same alpha subunit are HCG, LH, FSH, and TSH. Last question. What hormonal changes facilitate lactation? There's a drop in estrogen and progesterone after delivery, so you lose the inhibition of milk production. There's an increase in prolactin, which is responsible for milk secretion, as well as an increase in oxytocin, which stimulates milk ejection. That's it for now. I'll see you next time.